So another area that's been talked about here is that of novel targeted treatments. You know, we've been blessed in the last 10 to 15 years. We have the immunomodulatory drugs, thalidomide, lenalidomide, pomalidomide. We have the proteasome inhibitors, which have started out with bortezomib and now moved to carfilzomib, and we are hearing here about an oral proteasome inhibitor, ixazomib. And then we're hearing about other novel agents that are very exciting. The monoclonal antibodies, the CRIM1 inhibitors, new kinase inhibitors are being proposed. That's really very, very exciting, I think. But maybe I could ask you, any of you, what of these new targeted therapies do you think really is representing a major advance and has the most promise for patients?
So I'm kind of excited by the targeting the RAS pathway, the RAS-MAP kinase pathway. It clearly can be functional, and we've had some great data here from a German group talking about how mutation status doesn't always correlate exactly with that activation status of the pathway. And I think if we can pursue that to its logical conclusion, we should be able to ultimately to define who will respond to a kind of RAS-MAP kinase pathway inhibitor, minimize patient discomfort and actually get responses.
Well, it's very exciting. You know, I think the other side of that is that once we define these roadmaps or circuits that are allowing myeloma cell to grow, we can figure out whether a particular medicine works or doesn't. But even more importantly, we can figure out what side roads or what detours the myeloma cell uses to get around our treatments and allow myeloma to return.
So I'm quite interested in the whole apoptosis pathway, so the p53 mutations with ATM, ATR, and whether you could use that as an Achilles heel. I mean, they're resistant to chemotherapies, but if you could use something like a PARP inhibitor and a synthetic lethality strategy, that might be really good for that high-risk group of patients.
I agree. You know, the way we think about it, you said synthetic lethality, which I understand,
Yeah,
and I'm not sure the patients do that. So what I would say is it's sort of like the Achilles heel.
Yeah, absolutely.
We identify when we use a treatment, we know that maybe the treatment itself works or not, but it can be another Achilles heel that if we target that second target, then we get lethality for the myeloma cells. So I think that's a super concept. And what about immune therapies?
I'll take a stab at that. You know, it's like it's just incredible to see what has happened in the area of immunotherapy, and this is across the board in cancer. But certainly myeloma is not the exception, both by agents that stimulate our immune system and then makes that immune system go and fight the cancer cells, as well as by indirect strategies where you just tag something directly. To the latter in myeloma, the development of these antibodies that tag the surface of myeloma cells, I describe it to my patients. These are like anti-serums, like what you would get for snake bite, etc. But it's just that they go and they bind straight into the cancer cells, and then our immune system is primed to go and destroy that through various mechanisms. I think we have great promise in that, and one of the best parts is they probably will combine quite well with existing treatments. So if you put the right line up, we think there might be a future where this is going to be the winning combination for a good number of patients. And certainly other treatments, such as this other monoclonal elotuzumab, that is also having some results that are very, very promising towards harnessing our own immune cells' ability to kill the cancer cells.
And I think that's the great thing about those new immunotherapies and new antibodies that are emerging now and really will change the treatment of myeloma. The other thing is that they're agnostic to the mutation. So you could have a bad mutation or a good mutation, but if you have that surface antigen that will come and allow the immune system to attack the cell, the immune cells and the immune system can really attack a good myeloma or not so bad myeloma versus a very bad myeloma cell with efficiency. And I think combination therapy plus immune therapy will be the way to go for our patients.
No, I couldn't agree more. I do have to say that we don't use the word good and myeloma in the same sentence. Okay?
That's true.
But what I'm just teasing.
Not so bad versus very, very bad myeloma cells.
There you go. There you go. But in terms of the immune therapies, I would just add, I think the extreme power here is of our God-given immune systems. You know, we get a cold one day and we get better, and the next week we get bronchitis and we get better. So there's this incredible ability to adapt and remember the different exposures to which we've had, whether they be infections or other noxious stimuli, and the immune system is really able to adapt. So while myeloma is also rapidly evolving and mutating and changing and progressing, the immune system, I think, has the ability more than anything else we have to deal with such a changing enemy, if you will. And the other concept I think that we've learned from traditional chemotherapy is this of combination treatments. Mm-hmm. We talked about, blocking two different pathways perhaps, Gareth, but in the immune area, we've already learned, and this meeting is evidence of that. So the elotuzumab antibody that you mentioned, Rafael, is wonderful. It targets the myeloma cell. Once the antibody's there, it's marked for destruction. But it needs the help of lenalidomide to augment the host immune response, trigger the immune cells, and stop the immunosuppression, and allow that antibody to really facilitate those cells being destroyed. What is also exciting here is that things that haven't worked in the past, like vaccines and cancers, have not been, by and large, effective. They are going to be discussed in the combination approaches, so with lenalidomide. And other combinations, to just quick mention, are these checkpoint inhibitors. And I think we should spend a minute to let patients know about what those really are. So I'll just introduce it, and then I'd love to hear what you all think about the potential. But it turns out that myeloma, like other cancers, have this camouflage on their surface. The camouflage is called PD-L1. And the good guys, or the immune cells, the T cells and natural killer cells, they're the immune army to really marshal against the cancer, express what's called PD-1. And when PD-1 on the immune system reacts with PD-L1 on the target myeloma, it's a brake, it's a down-regulatory circuit. So even though the immune system's trying to react against myeloma, it can't. So the breakthrough is the ability to blow the fuse, to take the brakes off by using an antibody to either PD-1 on the immune cells or PD-L1 on the cancer cell, and allow the patient's own immune system to do what it really should be doing. And in melanoma and lung cancer, we already have such drugs FDA approved. In myeloma, we have a very exciting session about those kinds of strategies here, not only alone, but in combination with antibodies or with vaccines or with lenalidomide, the immunomodulatory drug. So are you all as excited about these combination immunotherapies as I am?
No, absolutely. I mean, the first step is to get the baseline in, and so elotuzumab, anti-CD38, daratumumab, the Sanofi compound. Once we can get those in the clinic, then I think, like we've done with chemotherapy, then you start to build your combinations. And it's kind of almost natural if lenalidomide enhances NK cell function. You provide a target for the NK cells with anti-CD38, and then you enhance their activity by using another molecule which upregulates the activity of the NK cells. So I think these sort of combination strategies will take us forward, and it kind of does help deal with the tumor heterogeneity and mop up all of the cells that are left after people are in a remission. So I think that's a great place to try it.
I think the other thing is sort of like HIV therapy. As we start getting into cancer therapy, multiple agents coming together, multiple drugs to overcome resistance, earlier treatment, the better. And we're starting to see that we're getting better and better in using the immune system, like you said, Ken, plus multiple combinations that kill the cancer cells and prevent progression. And we're changing already myeloma treatment. Every year we have new drugs, and it's really exciting. But the other thing is those antibodies are less toxic than the usual drugs we use. And I think as a patient, it would be great to take an antibody that potentially can kill the cells, but also activate the immune system and make it less less chances of it to come back and progress.
Right, and I think, you know, with your focus on the early myeloma, so-called smoldering myeloma, patients who wouldn't otherwise need treatment, their immune system is going to be pretty normal at that stage. So you would predict they would take advantage of these new strategies to the most, and maybe we could prevent progression or development of active disease. So I think we'll just try to summarize and say that this meeting is just another in a series. Every year it seems that it gets better. You might wonder that we're going to have advances to talk about, but it does really keep getting better. And what we've really said is that the genomics has allowed us to understand the disease, to understand prognosis and treatment even better with entirely new classes of medicines, that we can in fact treat earlier than we've ever treated before because the medicines are actually effective and well tolerated. And finally, that the immune area, I think would have to be said, is the most promising for us right now because it takes advantage of the intrinsic ability of the immune system to selectively remove large numbers of tumor cells, and because of its flexibility and adaptability, and probably can confer benefit even in high-risk myeloma or multiply relapsed disease when we have a lot of mutations, et cetera. So anyway, this has been a wonderful meeting. The outlook for myeloma has never been better, and I think many patients have chronic disease, and I do think there's a potential for cure in the future.